So I've been tasked with, giving a talk on molecular markers in prostate cancer, and what I'm going to do is part review of the literature and part, some of the work highlights in this specific area, from our center in Maryland. So just a quick recap. Most of people in the prostate cancer field know this, that so early detection because of PSA screening, and I'm kind of hearing the HPV screening discussion here. I've been thinking, this was a poster child for screening, and basically, there are other problems associated with early detection. So, but we do have early detection, effective treatment options for localized disease and significant disease in metastatic prostate cancer presentation. But there are challenges. We deal in the field, and essentially, we are looking at PSA is not prostate specific, prostate cancer specific, so improvements in diagnostic marker, and there's been a lot of say controversial or bad news about PSA lately, problems predicting clinical course of disease after early detection. I think this is a very important area, at least for urologists or the people who are in prostate cancer field. And then, of course, challenges still remain in the treatment of metastatic disease, which is, I think, highly prevalent in India. So research focusing on causal gene changes, and I'm a cancer biologist, so that has been my focus, but I also I'm fairly integrated with the urologists and geopathologists at our center. So anything I'm doing, it's always thinking, how we can improve the diagnostic setting with new biomarkers or potentially new therapeutic markers. So that's kind of, we're looking at. It's old and new, so PSA everyone knows about as a serum marker, but then there have been actually, several new FDA-approved, tests lately, and some in the space of, say, improving the diagnostic setting, some, as a urine assay, and basically another one in the post-prostatectomy setting. So I'm going to kind of give you quick overview of these tests which have been around. In terms of PSA, I'm not going to talk too much, but except the recent news, everyone knows about it, at least in the urology field, that United States Preventive Services Task Force recommended against PSA testing. I think, which is personally is a rash decision, because 20 years ago, when the PSA test was introduced, we used to see 20-30% patients with the metastatic disease there in U.S. And so I don't know the wisdom there, but there are I agree with some of the findings, and I guess we need some better tests. We need to be thinking beyond PSA, and that's the bottom line. AUA, ASCO, as well as American Cancer Society still maintain the recommendation, and I think, it's still a good position to take until we have something better than that, because PSA has been the poster child or marker, cancer marker for early detection in the entire cancer field. I think HPV in cervical cancer has beaten PSA to some extent, and perhaps more biological relevance, but clearly, so that has been the issue. So there is a new, relatively new, say, test. It's another form of PSA, not something completely different from PSA, and it's indicated for aiding in distinguishing prostate cancer from benign prostate condition and making biopsy decisions. So I'm not sure, it's going to be a whole lot better than PSA, but I think it has its utility. It's FDA approved. Then there's another test, it's called ProsView test, and which is measuring the very, very low levels of PSA in serum, and essentially after radical prostatectomy. So if you look at the slope of PSA rising after surgery to remove the say prostate gland, and the more steeper the rise is, that can predict say either the lack of recurrence after surgery. So this is a relatively new test being talked about, FDA approved. So I think it will see some value. Initial data looks good, and perhaps that's something to keep an eye on this. And then for last several years, at least I would say in my personal experience, 6-7 years in development, has been the Progensa PCA3 test. And PCA3 is a highly prostate cancer specific marker. So this essentially a score of PCA3 in urine, and this is a post-DRA urine. So this is not, a standard, say, unprocessed, normal urine. This is it is a urine collected after the digital rectal examination. So a score of 25 or above is associated a high likelihood of prostate cancer, and below it is a low likelihood of prostate cancer on biopsy. A lot of work has gone in this. I reviewed some of the work in Nature's Review in Urology about a year ago, and essentially large studies suggest that there is in the repeat biopsy setting, so if a patient comes high PSA, biopsy negative, then what you do? This is a test in that space that if the PCA3 is positive, then at least there's a cancer. Whether it is a clinically significant cancer or not, that's another question. But with the score of PCA3, perhaps it could guide you for repeat biopsy. So that's an area we are looking at. And then there's a major excitement in the field of prostate cancer research, at least at the molecular level, is that the discoveries of prostate cancer specific molecular changes. And I'm just going to talk about one here, which is the most prevalent. And I've been working on this also for quite some time now, for the last 7 years. That has been one of the primary focus of our center, at least in the molecular, say, genetic side of the story. So ERG is a TMPRSS, in the TMPRSS context, it's a gene fusion. So if you look at, in the normal context, we don't have the ERG expression. And in the prostate cancer context, we have, ERG protein is expressed as a result of gene fusion. So gene fusions do not happen, in normal cell context, except in the normal context. If anything you can think about, it will be immune system with a lot of rearrangements. But in cancer context, the fusions happen only in tumor cells. So it's a highly specific change, and the ERG is expressed increased amount under the control of a promoter, which is regulated by androgen receptor or male hormone receptor. So TMPRSS2 gets slammed into the ERG protein coding sequence, and you have so there's a mini industry, at least in the molecular side, trying to understand the ERG both for its biological function, its utility, because its specificity is about as good as it gets, and perhaps it could be useful also in prognostic setting, because it could be used in combination with other prognostic markers. Because it's a cancer-specific change, I mean, this could potentially be an HER2 or BCRC able for prostate cancer. So that's why there's a lot of excitement. And so Dr. Chinan's group, who has been actually the pioneer in the ERG fusion story, and we discovered, the ERG transcripts and in high amounts. So that group has shown that in a larger study, actually trying to look in the post-DRA urine, if they detect these gene fusion analytes, and essentially what they are showing is that if you're using, this is PSA for ROC curve, and compared to the PSA, if you're looking at the performance of the, say, TMPRSS-ERG fusion, along with PCA3 tests in the post-DRA urine, it's quite significant in terms of detecting clinically significant cancer. I think that's the bottom line. There's a lot of information here, but if you just focus on this slide, that's why it's selling. So I think there's a potential for PCA3 as well as ERG. These are the highly prostate cancer-specific changes. Detected in urine in the post-DRA urine context, I think it's important. And we should be looking this in more carefully in different populations. I think that's the message I would like to convey here, because even with this kind of specificities, we are looking at in different populations, perhaps there could be issues. And what we have shown in the U.S. that in African American patient populations, the ERG test is not as sensitive. And so I think something needs to be looked carefully. If people in India are going to be using this kind of approaches, we need to be thinking about at least setting the baseline and do the studies here. Then the last one, which is more in the space of more advanced disease, which has been successful in circulating tumor cells. In breast cancer context, it has been very, successful in following the treatment responses. And in metastatic prostate cancer, context, this test is beginning to be at least analyzed and looks promising. And I think Dr. Dalilo is going to be discussing CRPC. Probably he'll address this more. Just a few words about our center. So I'm from Center for Prostate Disease Research. It's a very integrated program for the cancer biologists, pathologists, urologists, as well as the medical informaticians and epidemiologists. So we have I'm privileged to be part of this activity as a co-director of the program. And of course, our focus has been biomarkers and therapeutic targets. So the ERG story actually developed, as an expression activation in over 2/3 of prostate cancer patients. And perhaps this is one of the most common, cancer gene defect as a defined, say pathway in prostate cancer. As I said earlier that, so there is a list of now the cancer-specific markers, unlike PSA, is emerging. And so AMOCAR is a tissue-based marker. PCA3 is done in urine, and the ERG can be done also in urine or tissue. This is the data from laser capture microdissected cells, with the cleanest way you can get the tumor cells from the tissues. And we're showing that if you take these three markers, it's a great combination of panel where you can detect 100% of tumor cells in the gland. And hopefully, although the company we were working earlier with, they had licensed from us this panel, but got more interested in Tempus ERG and PCA3 for good reason. But there's a potential that, perhaps these panels could be further developed with other modalities. So in the context of PCA3 or ERG, it's at post-DRE urine, we are looking at messenger RNA. And so it's a special type of specimen collection. And, but in the urology clinic, perhaps, could be done pretty, say, easily. But there's a special type of specimen is needed. So I was going to show you the data on ERG, which I just briefly mentioned, that so definitely the test, performs at least at the level, what we have seen in the data in the literature. But I think the point I wanted to make was that if we are looking at, say Caucasians versus African American patients, and here I'm showing the data for the Caucasian patients, you see great sensitivity in the PSA below 4 nanogram region, which is a gray zone essentially, for the specificity of the PSA. But same thing if we did with the African American patients, it doesn't work. So I think, you need to keep in mind that in different populations, these tests which are being developed and analyzed and established, in a given population, I think needs to be further analyzed. I want to conclude with some of the slides on a monoclonal antibody we have developed against, ERG fusion encoded protein. So the FISH assays or the molecular assays at the DNA level, they are, if you are set up to do those kind of assays in tissue is good, but the reality is, like any test we talk about, if it's a simple test, it catches up, like PSA. So that's why we developed the antibody-based test, simple immunohistochemistry, and it has been extremely exciting and successful, say opportunities, it has opened for us as researchers as well as potentially in the clinical setting. So the antibody which we have, and there's another antibody is also out there, it gives us the specificity of 99%, which nothing, not to say sneeze at. And then also we have pretty high concordance in terms of the immunodata with the FISH data. So clearly the changes at the DNA level correlate with the protein expression. The advantage is it's much easier to do, and you don't have to be even pathologist to kind of sort out this. So this is a normal gland which does not stain, and you can see the tumor gland is nicely, loaded. And these are clonal changes. There is endothelial cell staining, but that can be sorted out with the experienced pathologist. So we are developing a multiplex, panel assay, which is the future of most of the cancer markers. And here we have 4 markers together. So the brown or red is ERG, the greenish or blue tinge is AMOCAR, and then the basal markers are P63 and the keratin markers. So if you look at, this is a normal gland, which is nicely distinguished. And this is PIN. you have both the basal markers as well as the cancer, markers. And here we have essentially the carcinoma where your basal cells are gone, only cancer cells are done. So even as a non-pathologist, I could easily sort this out. So we're hoping that markers like this, will have the utility. So kind of quickly summarize that. So it's specificity of oncoprotein expression using simple assay of immunohistochemistry using a definitive marker which came out of the genomics word, but applying it in the context of the level of protein has been extremely, successful, at least in the early stages, and we are hoping that we can further, develop this, and then, of course, it could also stratify patients. Up until now, we have been stratifying prostate cancer by traditional pathology, by Gleason scores, by differentiation, and there's no molecular characterization, but I think the approaches like this will perhaps, will be a paradigm shift in terms of, characterizing prostate cancer, and hopefully the treatments will be developed around this. So the antibody has given a lot of opportunities, and we have a number of collaborations throughout the world. We are doing a study with Rajiv Gandhi Cancer Institute with Dr. Raval here, and hopefully, I'll talk in my presentation tomorrow at some of the data there. But just kind of recap here. So what I talked about, the new markers which are FDA approved, blood-based or urine-based assays. There are panel of markers such as AMACAR, PCA3, and ERG has potential. And then in the space of hormone receptor, in the context of castration-resistant prostate cancer, there are opportunities because ERG is an androgen receptor target. So perhaps ERG readouts will also be telling us about the treatment efficacy, at least if we are using the androgen signaling pathway. So we are quite optimistic, and we're doing a number of studies, with various groups in the U.S. and around the world that try to see how we can utilize both in the CRPC setting as well as in early stage prostate cancers. So I think I'm going to stop here, and thanks for the opportunity.
Thank you, Dr. Srivastava, for giving an excellent insight on the new markers for the prostate cancer, which is going to come up in future. And this is not going to help only for the diagnosis, also to develop the treatment modules, particularly in the expression of the oncoprotein. I feel a few urologists in the audience, and if anyone can ask a question to Dr. Srivastava.
Yeah, even though we have different biomarkers such as PSA and last year I attended one conference in Florida, AACR conference. There was one guy who showed the data. The people who are diagnosed with prostate cancer never died of prostate cancer. So could you?
Yeah. So I guess Dr. Mohanty probably can address that better, but that is an issue because we're detecting the cancer earlier and earlier. It's a slow-growing tumor, so people have been following up to 10 to 15 years. Typically, you have 15 years and on. At least in our database, we start seeing metastatic, metastasis data. PSA recurrence, unfortunately, it is not the best way to kind of monitor the disease. There's an issue with that also. So the problem is that we're detecting early, which is the similar issues. I was listening to the cervical cancer talks, so we detect early, which is great, but we brought another problem to us now, the prognosis. So one of the areas which we are working on and other groups are working on is how to define the early detected prostate cancer. Which one are going to be really bad and which one will kind of moderate disease and patient will not be affected with that. So those markers are hard to find, but there's a lot of work going on, and the two companies actually actively pursuing that as far as I know, and our own group is looking into that area. So there's a big thrust for looking at prognostic markers, which will help us in early detected prostate cancer, which one will progress, which will not. In general, you're right, that it's about 5 to 10% of the PSA screen, cancer. In, let's say, 10 to 15-year context, you'll have the metastatic disease, which is good because, when I started working in this field almost 20 years ago, at our center at Walter Reed, we used to have about 20% patients presenting with metastatic disease. Today, we don't have in 1% and less. So the screening has helped. I think we got into another problem now, which is a good cancer versus bad cancer. So I think it's a progress, and we probably will sort out at some point.